New study is shedding some light on prostate cancer treatment. The American Cancer Study expects more than 160,000 new cases of prostate cancer this year alone. It also expects more than 26,000 deaths because of the cancer. Now, according to the study, drugs used to block male hormones gave men with prostate cancer really a better chance at survival. There was also a better chance of the cancer then not spreading. Joining me this morning to discuss this is Dr. Ali Kazrayan with Kazrayan Urology. Good morning to you.
Good morning.
I'm sure you read this, and it gives hope, does it not, to those who have been diagnosed with cancer and then had the surgery?
It gives great hope, and it opens our eyes to the possibility of further personalizing care. So with this, we have, and one thing to keep in mind for the audience, they mentioned in this study that there was a 30% recurrence rate after prostatectomy. These cancers had positive margins, had extension out of the prostate, so it's a different grade or stage of cancer than if someone had a low-risk cancer and had a prostatectomy. A study out of Hopkins came out that showed people with very low-risk prostate cancer and a prostatectomy had a 2% recurrence rate. So this is a disease that warranted evaluations. Nowadays, we can even do genomics testing and look at the genetics of the prostate cancer and assess how aggressive the cancer is. So maybe we leap forward and add the hormone blockade they're talking about in a patient in a scenario that it improves their survival, their prostate cancer-specific survival, and recurrence rates and metastasis.
So then, for those who are diagnosed typically with prostate cancer, do you recommend that all of them then go undergo the surgery, or can they just treat it in some other way?
Great question. So managing your prostate cancer is a really personalized decision between you and your urologist. About 40–45% of the cancers that we diagnose now you can actually monitor with a thing called active surveillance if it's very low risk, low volume. Certain cancers need surgery. Certain cancers actually may benefit from radiation therapy. So these are personal decisions because the risks and the benefits are different. Nowadays, we actually have amazing new technology where we can do focal therapy. You can use a technology called HIFU, high intensity focused ultrasound, where you use ablation, and if you have a lesion in one area, that's what you treat, kind of similar to what they changed with the mastectomy versus the lumpectomy.
So you're not treating the whole, but just that particular spot. So let's talk a little bit about the new prostate cancer then tests. And are these tests then that are for someone who has recurring cancer, prostate cancer, or are these for those who, you know, maybe are already at a high risk based on family history?
So good question. So when you look at the personalization of care in general, that's a big thing that we talk about in healthcare. For prostate cancer, that begins with screening. So who to biopsy, who not to biopsy. You saw it before you mentioned the American Cancer Society mentioned there will be 160,000 new cases of prostate cancer this year. Last year was 180. The year before was about 230,000. The reason that's dropping is because it's not because the cancer's not there. We're seeing a decrease in screening based on the U.S. Preventative Services Task Force in 2012 that recommended against screening. So studies have come out showing that between 20 and 30% of low to intermediate to high risk cancers are being diagnosed later. And what I urge the audience to think about, screening saves lives. Yeah. Additionally, it may allow us to catch cancers when they're smaller and less aggressive, so we can
easier to treat then.
Easier to treat or monitor or do focal therapy. And now with MRI scans, the multiparametric MRI is an amazing thing to talk to your urologist about because it can show us whether there are any tumors or regions of interest within the prostate. And now we have the technology to fuse the MRI and the ultrasound with which we used to just do the standard biopsy, and we can target those lesions. So it allows us more precision and accuracy.
So at what age should you be screened?
Great question. And this is very controversial. If you look this up online, primary care physicians are confused because there are a lot of recommendations. Right. I fall back on a study that was done by the team at Memorial Sloan Kettering and a team in Sweden. They followed a Malmö study in Malmö, Sweden. They followed about 20-some thousand men for their lifetime. And they went back and found their PSAs. They took them out of freezers.
Which is the test that you can have a blood test.
Yeah, it's a blood test. The screening test for prostate cancer involves a rectal exam and the PSA test, which is a lab test. And they found that if your PSA was above 1.6 or that upper 10% of PSAs, your risk of having a clinically significant, possibly fatal prostate cancer was much higher. If your PSA at 45 was less than 1, your statistical likelihood of having a prostate cancer that was significant and may impact your life was significantly low. And they did a follow-up study that said if your PSA remained less than 1 at 60, your risk of having a significant prostate cancer wasn't 0, but it's fairly low.
So talk to your primary care doctor about having that test and when is the best age.
Personalize your care and make sure you talk to doctors who take care of prostate cancer because we know about all these tests.
Thank you very much,
Sure
Doc.
thing.
So for the latest health news, by the way, you can go to newsforjax.com where you can watch this interview later this morning on the morning show page. We'll be right back.